everyone, and welcome to my TED Talk presentation. Before I start, I would like to introduce a little bit of background information about myself. My name is Jacqueline Sitzler, and I have been in the medical field my entire life. My father was a physician, my mom was a nurse. I spent a ton of after-school hours in the hospital just waiting for one of them to come off. But in that time, I got the chance to watch how hard and how dedicated my parents were to providing good quality patient care. This actually inspired me to want to advocate for my patients, advocate for people, and to take care of people. So I started my career volunteering for an OBGYN office as a non-paid front office reception, until I pretty much turned 16 and was allowed to work a normal job. And then I kind of jumped around between many different specialty offices in many different positions, just so that I could learn all different aspects that the medical field actually had to offer and all the different types of jobs that there were out there. My last job that I had was an office manager for a pain management clinic, which I had recently just stepped down my position so that I could focus on finishing my nursing career. Throughout all of my time in the medical field, one thing that I've noticed in every specialty out there, didn't matter where it was, in every position that I did, patients were either being overtreated with unnecessary procedures or undertreated by being referred out to another physician, same specialty or a different specialty, or they were being referred to unnecessary procedures to try to figure out what's going on. And I'll give you an example. So an example would be, say you have a sore throat. So you go to your physician because most people feel confident in sharing information with their physicians more than they actually do with a specialty. But they go to their physician and they say, my throat hurts. I can't figure out what's wrong. It's been hurting for like a couple of days. So the physician looks at you. Either A, he's going to do the single line guideline treatments that he is required to do, where he examines you, swabs your throat for microbacterial, swabs your throat for bacteria to see if you have staph, and then he's going to prescribe you antibiotics, or he won't prescribe you antibiotics, or he's going to examine you and say, I don't know exactly what's wrong. I feel like it could be this. I'm going to refer you, and we'll just say an ENT, because an ENT takes care of your ears, nose, and throat. So you go to the ENT's office. What are they going to do? Well, they're going to examine you. They're going to order MRIs. They're going to order blood work. They're going to do a CT scan. I mean, they're going to do the works on you to figure out what's wrong. After they've done everything and they're like, well, it's not an ENT thing. I'm sorry, I can't help you. I'm going to refer you to a GI doctor. Probably it's not postnasal drainage. It's either acid reflux. So you go see the GI doctor. He's going to do all of his special tests. Barium swallows, 24 acid reflux tests, try to figure out what's wrong with you. He's going to put you on tons of medication. He's going to be on proton pump inhibitors and H2 blockers and all these things to try to figure out what's causing this sore throat. But after all your tests come back, and if they come back negative, you don't have a hiatal hernia that's causing the acid reflux. There's no actual damage to the esophagus during a bronchoscopy. He's going to be like, well, I don't really quite know. Maybe you just have postnasal drainage time to time because you have allergies. So then you get referred to an allergist, who then they are going to run their test, where they're going to make sure that they do all of the testing on your skin, you know, these little pricks, to see if maybe you have an allergic reaction to them. But what happens if your skin comes back negative? You're not allergic to anything. Or maybe it's very mild that you're allergic to, I don't know, say something like fish oil, but then you're like, I haven't had fish oil in so long, I just can't figure out why my throat hurts. Well, he's gonna probably go, well, maybe it's a thyroid issue, out of the blue, right? So then you go see a thyroid doctor, or sorry, an endocrinologist, and he's going to do his radioiodine uptake tests that you're gonna have to try to stay away from people for at least 2 days because they're gonna stick some radioactive stuff inside you to figure out what's wrong. They're gonna run blood work, probably almost the same blood work as before, but brand new blood work to see if anything has changed. And if anything all comes back, they're gonna refer you back to the primary care. Go back to the primary care and you're gonna tell them, I saw the ENT, the GI doctor, the allergist, the endocrinologist. And he's gonna be like, well, the only thing I can possibly think of is maybe you need to go see an oncologist. So then you go see an oncologist who finds out that it was a little tiny cancer that you had in one of your lymph nodes that just didn't quite show up or something, and he's either going to want to do surgery on you, or the most extreme invasive surgeries or procedures where they do radiology, or sorry, oh my gosh, I can't talk right now, chemotherapy or radiation. But during all of this time, you're either being overtreated, overdiagnosed with all of these things, or you're being undertreated because you're being shoved off to the next physician, shoved off to the next specialist. There's so many times that I have talked to patients where they're like, oh yeah, my doctor said this, and so he's referring me here. And it's like, well, that doesn't sound quite right. So as physicians, or sorry, as healthcare workers, we need to be able to advocate for our patients and stop this overtreatment and undertreatment issue that's kind of going on. Now, let me give you the definitions. So overtreatment or overdiagnosing is a diagnosis that is correct according to the standards, but the association or associated treatment has low probability or benefits to the patient and could possibly cause harm. Then there's undertreatment or misdiagnosing, which occurs when physicians fail to accurately diagnose patients or refer patients due to the disease not falling underneath the physician's line of practice. So why are all these things a problem? If you're getting treatments, you would think, hey, great, you know, they're getting cared for. Well, yes, but no. A lot of times the over and under treatment causes excessive amount of spending nationally. In fact, the Institution of Medicine states that unnecessary healthcare services waste approximately $210 billion a year only within the United States. And this can also lead to people funds taken away from people who need to have medical treatments. Patients often suffer unnecessary outcomes from these treatments as well, or undesirable effects. Sometimes the dangers of the side effects from the medications, sometimes it's the polypharmacology that comes from mixing medications. It can contribute to the proliferation of antimicrobial resistance as well. When you overtreat patients with the antibiotics, they're continuously being treated for it. They're eventually, the bacteria or whatever they have inside them is going to become immune to that bacteria or that antibiotic. So it's not going to work for them in the future for that or for whatever they're actually being treated for. On top of it, let's see. Patients are offered unnecessary and inappropriate treatment that have little to no benefit to them. So there was a study done over 2,010 physicians who actually stated that 30 to 45% of them prescribe medication, or sorry, medical care, unnecessary medical care to patients. 22% of physicians said that they write unnecessary medications because they feel like they just needed to do something. 37.7% of physicians perform unnecessary tests because they just don't quite know what's going on, so they feel like a test might explain. And 16.2% perform unnecessary procedures. This can cause a lot of psychological effects on patients, causing unnecessary fear and anxiety and an increase of vulnerability, depression even, and then the psychological suffering related to an actual medical label of being diseased. This can also cause economic burden on the patient themselves. Increased spending increases with the cost of healthcare insurance, making it harder to obtain insurance. Yes, sorry, I lost track as to where I was. So what causes all of these physicians to overtreat patients? Well, for one, there's always new screening that's coming out, always new genetic testing. So physicians aggressively screen patients and increase the sensitivity of diagnostic tests because physicians hope that they can catch or detect early detection of a disease, and they hope for a better prognosis inside their patients. So they will overtreat any tiny non-progressive or regressive abnormality that they can find during these procedures or screenings, because they think that it's an early diagnosis, when in fact it's just normal anatomy change, or it's something that is completely benign and it's not going to actually kill or harm the patient. Another thing would be the expand disease definition and the lowering of the thresholds. So what I mean by this is, and I'm going to give you an example, patients who barely meet the criteria for hypertension are going to be permanently labeled for the rest of their life that they have hypertension, which is going back to the psychological effect I said. It's going to cause them to have prolonged treatment for the rest of their life, because hypertension is one of those things that you want to treat early and manage as much as possible to prevent cardiac issues later on in life. And then, of course, they're going to be prescribed medications that really aren't going to do any benefit for them, and it doesn't decrease their mortality or their morbidity rate. Instead, physicians can treat patients a different way by discussing more or less like life-changing effects to prevent them from going into hypertension. It's just pre-hypertension, but because the expansion of the diagnosis of it's now a point where it's a disease itself. It's no longer just something that's borderline. And I can give you another diagnosis or another example. So another example would be overtreating older patients with depression, which then they get treated with antidepressants because a lot of non-invasive behavioral activation techniques, because physicians feel like they just don't have enough time to spend with patients to teach them this type of technique. So they were more or less inclined to say, well, you're depressed, take a pill. 85% of physicians actually stated that they fear malpractice due to misdiagnosing a patient or the patient's not meeting the patient's expectation, which this fear is actually a false reality. And I say that because there was a study done where only 2 to 3% of patients who were actually harmed due to neglect or an adverse effect filed litigation against physicians, and then only half of that 2 to 3% would receive compensation or has received compensation, where the other half was usually declined. So the rate or the risk of actually getting a malpractice lawsuit against you is really low, as long as you follow the guidelines that you're supposed to. But also, a rule of thumb, you're supposed to document. So studies have shown that with proper documentation, honest disclosure, and an apology can actually go a long way in mitigating a litigation against malpractice. And then there's always the ethical oath that all physicians have taken to do no harm. As long as you strive to do no harm, you're not doing any harm for your patients. So then there's the 59% of physicians who overtreat due to the pressure of the patients and demand. This self-referring method is most of the time due to patients not understanding the difference between the risks and the actual disease itself. And also a lot of it has to do with public advertisements pushing for people to get screened and tested in order to gain reassurance that they don't have a certain disease. And a good example of this is the genetic testing out there. Advertisements all the time push for, well, do the genetic testing so that you know you don't have the markers of a certain cancer that's going to kill you way later in life, or may not kill you way later in life. So then patients get freaked out and they go to their doctor and they demand to actually have these genetic testings. So then there's, 38% other causes as to what would cause the overtreatment. 38% physicians stated they have difficulty accessing medical records. So imaging and treatment options are usually repeated. And then let's see, other physicians, there's people out there that actually believe that physicians prescribe more unnecessary procedures when they benefit from them through financial incentives. So an example of this one would be that physicians are given a bonus for an increased productivity related to clinical volume, and they're also given a free fee-for-service reimbursement for more primary health care visits, referring patients to specialists, doing more diagnostic tests on patients, and then doing the curative services. And then let's see, another reason why overtreatment, or what would cause overtreatment. 40 physicians say that it's due to the inadequate and lack of time spent with patients. I kind of said a little bit of this earlier, but physicians feel like they just don't have enough time to provide behavioral counseling. And I'll give you an example for like smoking or weight loss sensation to help reduce these, because these are things that if you catch early and reduce, you're going to prevent a lot of complications later on. But because they don't have time to counsel these patients, they usually end up referring them to a surgeon for, do the tummy tucks, or they give them medication to help reduce the cravings for the nicotine and stuff like that, which then causes the overtreatment. And then some physicians state they define there's the social perspective of trying to fit in their practice and customs. And also, all physicians are required to follow clinical guidelines. So what are clinical guidelines? Clinical guidelines are single disease guidelines that are used solely for the purpose of influencing a decision of a health intervention, which encourages them to do more rather than less, which as a result causes physicians to be practice defensive medicine, And whereas physicians just want to be more on the safer side. So they'll actually treat you because they'll say, well, just in case, we want to be on the safe side about this. And these single guidelines don't account for multiple actual prognoses or diseases. So it gets really confusing when a patient comes in with multiple issues on these single condition guidelines, and it can lead to the polypharmacology that we talked about, reduce the quality of life of the patient, and can cause some serious adverse effects. Clinical guidelines can also be used for physicians or against physicians by during malpractice, by either attacking them or justifying their care given to a patient if the patient was to have an adverse effect. And some physicians, some grouped physicians, some grouped physicians out there, not saying all of them do it, but they do use the clinical guidelines to attack other physicians in order to protect their clinical turf. And then other reasons that cause overtreatment is some physicians out there are just insufficient in the knowledge of the nature of history of the disease. So if I was to implement any fixes to these problems, what would they be? So possible solutions to the problems would be easier access to outside healthcare. There was actually a study done in California and Florida within emergency department rooms that showed that regional exchange of electronic health information resulted in a reduction of repeated chest x-rays by 13%, repeat ultrasounds by 9.1%, and CT scans by 8.7%. Being able to access healthcare information national-wide between physicians in the actual hospital could estimate in 78 billion net savings a year. Another possible solution would be developing practice guidelines with patient-centered evidence-based practice data. Since fragmented and outdated practice guidelines have been proven to contribute to the problem of overdiagnosing. Future guidelines should consider overtreatment consequences, offer more than binary recommendations, and include resources that could help physicians interpret the complexity of benefits versus harm when patients have multiple conditions. Another solution is that we can change these financial incentives that physicians are getting to reduce healthcare waste, such as rewarding physicians for shared decision-making with patients. So studies have indicated that an increased patient education and shared decision-making between physicians and their patients results in more conservative treatment. Nurses can even help during this whole process by being the common voice for the representatives, or for the patients. Another thing is this also allows the ethical consideration, such as encouraging patients to use their voice, because it increases patient autonomy. It increases the do no harm type thing, and it also allows patients to make the well-informed consent about their care versus just doing what they were told was the right thing to do. By allowing patients to make their own decisions, this is going to help reduce unnecessary services by 50%. And it could result in a $105 billion in savings each year, which accounts for 4% of the total national healthcare spending that we do currently. Additionally, we can also do fee-for-service physician compensation to help reduce the utilization and the cost of overtreating patients. Other solutions that we can introduce are educational programs in training our residents, training nurses as well during this process, appropriate criteria, and the benefits of thorough documentation. There's a lot of just, if you write down exactly what's going on, then there's not a lot that can be held against you. Unless you're actually doing something wrong, which I hope you're not. But educating them about how to properly document and what benefits behavioral change supports can actually provide for patients, which hopefully would deter physicians away from invasive procedures or the urge of writing a prescription for something first. Then let's see, another solution is nurses could also help in the development of education-based decision-making tools for patients so that they can gain a better understanding of the harm and the benefits of treatment methods and screenings. That's one of the most important roles about a nurse, and that's what I actually really love about nurses. We advocate for patients, and we are the ones that say, hey, this is what actually goes on, and you need to know what kind of benefits you're going to receive from this, what kind of possible side effects are possibly going to happen from this, and we educate them as much as possible so that they can make the decision themselves if they feel like it's something that would actually help them, if it's something that they would want to do, or if maybe they need to ask if there's something more or something else that has less possible side effects. So as nurses, we can definitely advocate for our patients. And then another solution that we can do for trying to prevent the overtreatment or undertreatment of medicine is internal resources, or we can utilize internal resources such as an awareness campaign that has been shown to bring awareness to the actual problem at hand and provide methods to reduce the overtreatment and undertreatment. A couple of these internal evidence sources include the Choosing Wisely campaign, which was launched by the American Board of Internal Medicine to provide recommendations for things for physicians not to do, provide information of resources for physicians to use during shared decision-making practice with patients, and it also provides a long list of questions that patients can use to ask their physician in order to gain knowledge about tests, treatment necessities, risks or benefits of alternative options, consequences of just doing nothing. There's also the Less is More campaign. That's from the JAMA intern medicine. There's the Too Much Medicine campaign. That's by the BMJs. And then they always suggest that, you know, if you have a patient who you actually do think has some psychological things going on, but you're not sure how to actually test them without doing all these invasive procedures or just diagnosing them or sending them off somewhere, they recommend that you always use the DSM-5 release, which is can tremendously increase the number of patients being given the level of psychological illnesses that are out there. And if you want, I can put a link down below of all of these campaigns that you can actually get onto if you would like to further investigate inside those. So the theory of my TED Talk today that I have used is a little bit of my own personal history and also the information gathered through outcome research. I hope you enjoyed this TED Talk presentation, and thank you very much for watching.